Hello guys, hello everyone. So yes, Diwali is done. Still festive season going on everywhere because near to my place still Years are going on. So yeah, it will continue I guess till New Year's. Hope you guys are doing good. So welcome to DRDCA scientific session, and it's a Thursday session that is midweek session. We are left with few sessions only now. So thanks to everyone who's joining, who's taking out time and joining. Today we are going to talk about something interesting. Not talking about endo or anything like that. Last sessions have been completely about endo, and there was aesthetics in the last session. Amazing sessions, I must say. So for those who are joining me for the first time, I'm Dr. Pallavi Mahajan, an endodontist, a writer, and a spoken word artist. So basically, I write poetry in Hindustani language and I share it. I present it on stage. So yeah, that's what I do. And the thing that should you should it should concern you is the fact that I'll be your host for. I have been the host for the scientific sessions in DRDC 2020. Dental Reach Digital Conference and Awards 2020 International has been an amazing conference. There's a very famous quote that associate with people who are likely to improve you. So, to be honest, I am very blessed to be associated with DRDCA, and I'm very glad that they told me to, be a part of scientific sessions, especially. Lots to learn, and on that note, I must tell you that if you have not downloaded the app or have not registered yourself for the conference, it's bad. Okay, so please do it. Do register for the conference. And since conference is almost like there are 5 sessions, 4 sessions left now. So DJ night is also planned. A lot of things are planned. Coming back to scientific sessions, we have been having scientific sessions every Thursday, Saturday, and Sunday. The whole month of November we are still having. And today, every weekend, every week, there are amazing speakers who are joining us. There are 40 speakers who are with us from all over the world, and speaking upon their fields of expertise. So today we are going to discuss about implants, about edentulous patients, something like that. So I remember there was a time when we used to think that it was a common notion that, after implant placement, you have to give some time for the healing of implant. It should stabilize and there should not be any loading in between that period. Uh, but it took a change. It took, I think, a next step came when there was an introduction of the concept called immediate loading. So today, the first speaker that we have is going to talk about immediate loading in edentulous patients. We have Dr. Prem Kariyappa joining us. He's an implantologist uh, and has his own private practice in Mumbai since 2003. Dr. Prem Kariyappa did his BDS followed by PG diploma from oral and maxillofacial implantology from France. He's a scientific coordinator on NCII OMFI, which is Shahnawaz International Institute of Oral and Maxillofacial Implantology. He has been a former lecturer in Yerala Dental College, Navi Mumbai, former consultant for oral implantology with head and neck rehab post cancer therapy at Bethany Hospital, Thane. He is the member of Indian Society of Oral Implantologists. Also, is the member of Hemophilia Society. So, Dr. Prem Kariyappa, as I said, is going to tell us about the concept of immediate loading in edentulous patients. We talk about a patient, a young patient who lost his tooth, and we give him the implant and everything. But edentulous patients have always been, a dilemma for many clinicians. So Dr. Prem Kariyappa is here with us, discussing all these things. So before just joins me. International Men's Day. Today is International Men's Day. So wish all of you International Men's Day. And tell you something. I'll recite something for you in the end. Also remember the questions. You keep posting your questions in the comment box, whether on Facebook, on YouTube, and the questions will be taken up at the end of the session. So now I invite Dr. Prem Kariyappa. So the screen is yours. Good evening.
Hello, good evening, Dr. Majan.
Good evening.
As you said, association is very, very important. There is a say that, show me your friends, I'll tell you who you are. Association is very, very important, in this today's date. And wish you a happy Diwali, and I wish all the DRDCA committee for the phenomenal job in this pandemic, and you guys are doing a great job. And a 1 month whole session, you guys are conducting it in a very well, and there are many more lectures, scientific session to come. And I wish you all the best. And you guys are doing really phenomenal work. And thank you for your kind words as well.
Thank you, sir.
Yeah,
You can share the screen, sir.
yeah, yeah.
We can see the screen, sir. Yes, sir.
All right, all right. So let me wish all the viewers, wish you a happy New Year and happy Diwali, and may this year brings all the light and brightness in your life. And so we get rid of this pandemic by end of this year. Hopefully 2021 start with the new fresh, the bright light of everyone's life. So I'm here to present my topic of the day, which is immediate loading protocol in edentulous condition. And today's scenario, this is my content of the my presentation. So I'll just let me run through my content, which is immediate versus delayed loading, merits and demerits, indications and contraindications, rationale for immediate loading, diagnosis and treatment planning, factor that influences the immediate occlusal loading, primary stability, diet, risk of immediate loading protocols, review of literature, conclusion, and the references which I've taken from. And also, I'll be sharing cases which we do in our office regularly on immediate loading protocol. Let me share all those surgical protocol and the prosthetic protocol with you guys. Okay. See, this is the scenario with the geriatric patient today. They all want teeth, uh, in teeth, in the sense it becomes a dentist's responsibility, uh, just not giving a teeth. It is also you need to achieve all three protocol, which is function, which is aesthetic, and the phonetics all together. You need to achieve it. Is just not only teeth for the patient. Probably he might be looking only a year, she might be looking only for the teeth, but it becomes our responsibility to give all three protocol to the immediate loading protocol. And let me tell you another survey which has been done by India, which shows almost in 2009 they've did a survey. Almost 10 million people in our country are edentulous patients. I don't know whether to put this as a right or a wrong, but I would look at it in this way: like, we can still have a lot of moral responsibility to treat these kind of patients. And also I would say it's bad because probably we have neglected, or we are not looked after these kind of patients in our dentistry. So we should always think it in a positive way, and we still have a lot of hopes and future for these kind of patients to treat in our society. So what is immediate loading? Immediate loading of a dental implant has recently gained a popularity due to several factors, that including, first of all, implantology is a surgical protocol. So always you must need to talk to your patients first. You must explain the procedure from the pin to piano, from start to end. You must explain the entire procedure, how it is going to be done, and how many appointments you're going to have it with your patients, and what is the surgical protocol, and what are the prosthetic protocol you're going to have with the entire protocol has to be discussed with the patient, including your cost factor. Everything has to be discussed in detail with your patient. And once a patient explained every procedure, if he's willing to go, then we can always think of planning is planning is a prosthetic phase or a surgical phase by doing an implant. In immediate loading, what are the things you look into? It it has an advantages of reduction in treatment time and trauma. Trauma is one thing which a geriatric patients will are more apprehensive because they have to undergo a surgery. The moment you mention the surgery, that can be that itself is a psychologically or morally it puts the patients down. You know, aesthetic and physiological benefits to the patient because you are giving it immediately. Patient diet is maintained immediately post surgery. Second, say surgery is not required, which is beneficial to patients for a psychological manner. So against immediate loading, so what we have it in a delayed protocol, patients have to wait for 3 to 6 months. They face a problem like a challenges in consuming that, or a speech, and most importantly, a lack of confidence going out without a teeth. All these many years they lived with their teeth, and they suddenly when they don't have a teeth, they have a lot of challenges in their phonetics, in their appearance, in the these are the things which always they think, and at point of time in their age, the age is a dominating factor at that point of time. They always think it is they've been neglected, they've been ignored in the society. So these are the things which come into their mind. So this is the reason that we can think of giving them a heat immediate loading protocols. Two-stage surgical protocol which brings down the patient's psychological status, as I mentioned. Obtaining and maintaining a soft tissue cover over the implant for 3 to 6 months is another challenge again. Maintaining a non-loaded environment for 3 to 6 months without any teeth, keeping the implants within the alveolar bone for 3 to 6 months, or sometimes you can even think of giving a provisional processes which has a different disadvantages altogether. So let's see in the furthermore slides how we go about with these kind of protocols. Let's see what are the merits and demerits. These are the merits. Need to maintain a removable provisional processes is eliminated. So you don't need to give any provisional processes. Provisional by giving a provisional processes, it has its own disadvantages because it has always it has a movement in the alveolar bone, and on the alveolar bone it can resorb the alveolar bone, which can lead to exposure of your cover screw or implant, or also bone loss around the buccal aspect. These are all the disadvantages of by giving a provisional processes, so which has been eliminated in immediate loading protocol. Provides an emotional benefits for the patient, improves the bone healing, facilitate a soft tissue shaping. It contours the soft tissue. It guides the soft tissue when you give a immediate uh, denture or immediate achilles teeth. Eliminates the premature implant exposure, often associated with wearing of removable denture during the healing period. Let's see what are the demerits. A micro movement of the implant that can cause a crestal bone loss, or it can lead to an implant failure for a greater than two-stage procedure. A direct visual evaluation of crestal bone during a second stage surgery is lost. So when you do a second stage surgery, you always expose the implant by giving an incision to the soft tissue. During that time, you can always make out what kind of a bone you have around the implant, whether your implant is submerged or its threads are exposed. So these are all the visualizations that you can observe in the second stage. Too soft bone, a small implant diameter, or an implant design with less surface area may cause a too great crestal stress contour and causes a loss of bone and leads to failure of implants. These are the demerits. Let's see what are the indications and contraindications. Indications are adequate bone quality. Adequate bone quality in the sense I would like to explain in terms of French volumetric classification by the late Professor Manuel Chanovas. He has categorized in category A, B, C, and N. What is category A? Category A is wherein you have a adequate amount of alveolar bone in terms of height, width, and breadth, and whereas in category B is wherein you don't have you have a inadequate amount of width in alveolar bone, you have an adequate amount of height and breadth, and category C is wherein you don't have adequate amount of width as well as height in alveolar bone, you have only basal bone. And then when category N is wherein you complete loss of alveolar bone, you have only basal bone, and also you're approaching towards inferior neurovascular bundle, ability to achieve an adequate anteroposterior spread between the implants. A poor AP spread decreases the mechanical advantages gained by splinting and ability of cantilever the restoration. Contraindications. Let's see what are the contraindications. Poor systemic health, that could be recent myocardial infarction, recent valvular processes, severe renal disorders, chronic or a severe alcoholism, a generalized secondary osteoporosis, treatment resistance diabetes. These are the condition you need to evaluate before you plan any kind of a fixed processes or an implant surgery for the patient. These are all has to be rectified with the with their physician, and then you have to move ahead with the treatment protocol. A poor quality bone. What are the conditions when you have a very poor quality bone? Treatment resistance, osteomalacia, uh, radiotherapy, post carcinogenic patients, severe hormonal deficiency, drug addictions, heavy smoking habits, IV bisphosphonate therapy, and immunosuppression patients. These are all the patients wherein you expect a poor bone quality. So you need to evaluate these kind of conditions, and also a bone height less than 8 millimeter, bone width less than 4 millimeter is a challenging case for immediate loading protocol. Inability to achieve an adequate AP spread. So that means when you don't have a inadequate breadth AP distance, so in that case it is a contraindication. So you might have to design your, or you might have to plan your implant placement accordingly to achieve your cantilever forces on the posterior region. Rationale for immediate loading. So that is A is surgical trauma. A bone interface is stronger on the day of implant placement. So when the day you place the implant, the bone to implant interface is stronger when it compared to 3 months later. A surgical process of an implant osteotomy preparation and implant insertion causes a regional accelerated phenomena of the bone repair around the implant surface interface. This is also known as RAP. So whenever you injured any kind of osseous structure, so there is a cellular activity becomes accelerated in that particular region. So that is called as a regional accelerated phenomena. The implant bone interface is the weakest and the most risky to overload for between 3 to 6 weeks due to bone remodeling at this interface. During this 3 to 6 weeks time, you can never think of immediate loading, or you can never think of approaching the implant back again, because that is where is the interface between the bone and the implant is going on. So that's when you need to leave them alone. So not to touch during this time, this period. Causes such as a thermal injury or a microfracture of the bone. So it could be thermal injury or it could be chemical injury that can lead to a microfracture of a bone, can lead to osteonecrosis and fibrous encapsulation of the implant. So whenever when there is a thermal injury or a chemical injury, there'll be a bone necrosis around your implants. So the fibrous tissue can encapsulate from the soft tissue. The fibrous tissue can encapsulate around the implant. It can lead. Rated may depend on the amount of bone prepared by drilling design and the sharpness of your drills, depth of your osteotomy, and the irrigation and the RPM of the drill. Irrigation, always we prefer having a chilled saline, and also RPM also has to be maintained by the company instructions during the osteotomy. And always according to the company instructions, you need to follow whether the drills are to be used number of cases. You need to change them often and again, so that as and then you uses it becomes blunt, so you need to keep on changing them for a better quality of osteotomy. Bone loading trauma. The own bone of a surgical trauma has been called a repair bone. The own bone formed from the mechanical or a loading response may be called as a reactive own bone. Remodeling from a mechanical strain or a bone turnover permits the repair of the bone after a trauma, allows the bone to respond to its local mechanical environment. Lamellar bone is organized, highly mineralized, is the strongest bone type, has the highest modulus of elasticity. it load bearing bone it is. Oven bone is in comparison is unorganized, less mineralized, and it is weaker and more flexible, though it forms at a faster rate than the lamella bone. The rationale for immediate loading, hence, is not only to minimize the oven bone formation or a fibrous tissue formation, but also to promote a lamellar bone maturation to sustain the occlusal load. So let's see what are the diagnosis and the treatment planning. So you need to, this is a very important step when the patient comes to your office. You need to understand what kind of a case you have got and how do you diagnose this and what is the treatment planning you think of. Always treatment plan starts first and then you come into a diagnosis when you see the case first. So you need to understand how do we do the diagnosis when you see an edentulous patient. So, but if you look at this picture, it illustrates there is absolutely no resorption when there is a teeth. You have a healthy bone, healthy alveolar bone, absolutely whatsoever. There's no resorption in the alveolar bone. If there is any bone teeth loss, you can see a mild to moderate resorption as you see in the picture. If you leave it for a longer time, if the patient doesn't fix up a teeth, if he keeps the edentulous area for a longer time, he completely loses a complete alveolar bone losses there. That is known as advanced bone resorption. Similar fashion is also seen in the mandible as well. In maxilla, it is the bone resorption pattern is called a centripetal type, and in mandible, its bone resorption pattern is called centrifugal type. Let's see how do we do the diagnosis and treatment planning. Factors that influences the immediate occlusal loadings are a number of implants, size of implants, design of implants, implant body surface conditions, and implant positioning. Factor that influences are the number one is number of implants. The functional surface area for an occlusal load at an implant interface can be increased by increasing the number of implants. We always prefer in our institute number of implants. If you can have it, it has a better predictability and a better stability for the future. The decrease in the number of pontic may also decreases the risk of fracture of a transitional processes, which could have again be a source of overload for the remaining implants. When there is a transitional processes has any kind of a damage, your remaining implants have to have a load bearing capacity. Otherwise, they can lead to furthermore implant failure in their remaining implants. In maxilla, you can always have a minimum of 4 implants, maximum of 12 implants. In mandible, again, a minimum of 4 implants and maximum of 9 implants are recommended. Increased number of implants may be used in case of reduced bone density in either arches. When you see a D4 type of a bone, you can always think of going more number of implants in that kind of condition. So let's come to the implant sizes. Always provided that if you have an adequate amount of height, you should always prefer to go with a longer implant, lengthier implants. Is more relevant factor in case of immediate loading, especially in case of softer bone. For every 3 minutes increase in implant, the overall surface area will increase by 20%. The additional implant length may also permit the implant to engage the opposing cortical plate. Suppose when you are placing in the premaxillary region, you have a nasal floor where you get a cortical bone there, whereas in posterior region you get a sinus floor which is a cortical bone again. So you can always engage your implants by using a lengthier implants in the bicortical to get the bicortical stabilization. You can always engage your implant to cortical plates. So let's come to the implant design. Threaded implants are preferred in comparison with the press fit implants because nowadays I don't think so anybody it's less recommended in terms of press fit implants. Increasing the number and depth of threads corresponds to increase in the functional surface area of the implant, hence corresponds to better load distribution, which is critical in success of immediate loading for implants. The thread depth of implant body is related to initial function surface area for the immediate load. So the depth between the pitch, between the thread depth is a more important factor when it comes to an immediate loading. And also the number of threads, the thread design. These are all the important factors for the immediate loading. Implant design affects the functional surface area more than an implant size. The square threaded designs are better than a V-shaped threaded designs. Parallel wall threadeds are better for immediate loading than the tapered threadeds. So these are all the when it comes to implant design. So besides this tapered implants and the threaded implants, we also have um, uh, pterygoid implants or zygomatic implants, whereas the threads are being situated at the apical engaging area where you see only threaded at the zygomatic buttress. So I'll be able to show you the designs in the next slide. Implant body surface conditions. This is another important factor. The surface area, the surface treated implants are designed in various factor, which is implant surface conditions, affects the rate of bone contact, lamellar bone formation, and a percentage of bone contact which are beneficial in immediate loading. HA coated decreases the remodeling rate, therefore the beneficial in D4 bone, and may decrease the risk in case of immediate loading. Calcium phosphate coated and titanium plasma sprayed also have been found in increase in bone to implant contact. Coating or a surface condition is the most beneficial during the initial healing and early loading conditions. So these are all the different designs of implants positionings you can see in immediate loading. Splinted arch opposition concepts is an advantageous in immediate loading as it is effective in reducing stress to entire implant support system. In the complete edentulous maxilla, the anterior implants, bilateral canine position, and in posterior implants, first to second molar position. For the largest anteroposterior dimension, when forces are greater, the dentist, we should always insert additional implants between the canines. So that could be in the premaxillary region. You can always think of going in additional implants. In mandible, at least 3 implants, one in the anterior and one in each posterior region are necessary. It can also called as tripoding implants. So if you see the pictures, it is illustrating when there is absolutely no bone up to the premaxillary region. Maybe it could be up to central incisor. You can always think of tilted implants, which will be emerging at the second and the second lateral incisor area, and then the second tilted implants would emerge at the second premolar region area. Bone available until lateral incisors is you can think of going for a straight implant at the lateral incisor, and you can think of going for a tilted implant in the posterior region, that is at the zone C region, that is second premolar region. Bone available until the first premolar, you can always think of putting one say, straight implant in the incisal region, and you can think of placing an tilted implant at the premolar region. And if you have a if you have a bone up to second premolar, you can have a think. You can think of second tilted implant at the second premolar region. So this can give you AP spread to have a cantilever first and second molar. And bone availability until first molar, you can always think of getting an anteroposterior spread in a comfortable way. So if you have a good bone volume, you can always think of placing 6 implants, 8 implants, or 10 implants, or 12 implants. So for a better stability, based on your quality of bone, you can always think of deciding. You can always go ahead with the number of implants decision on that. Let's see what is the bone quality. The modulus of elasticity of bone is related to the bone quality. The less dense of bone, the lower the modulus. The strength of bone is also directly related to the density of the bone. The amount of bone implant contact is also decreased for a less dense bone. Cortical bone is more likely to remain lamellar in structure during the immediate loading process compared with the trabecular bone. More implants, larger implants, a greater surface area, implant design, implant position with a greater AP dimension reduces the cantilever shall also be considered in a lower density bone types. Primary stability, which is the most important factor when it comes to immediate loading protocol. What is primary stability? Primary stability is one of the most critical factor and must be obtained at the time of implant insertion before any load is applied. That means you must have a maximum bone to implant contact. That can be in insertion torque, it can be minimum of 30, and in if you take a device, it should be minimum 60 to 70. It shows ISQ value of 60 to 70. That should be a primary stability when you think of immediate loading. So I'll be explaining in the near coming slides about the primary stability. This is the device. This is called resonance frequency analysis. It's an electronic device which is able to measure the damping characteristics of periodontium in a very reproducible way. Permits the objective discrimination between an implant that has closed bone position and one that is a fibrous encapsulation. A value ranging from -8 to -50, and this is the values which are given for the integrated and non-integrated bone and implant contact. Resonant frequency analysis also measures. It's a device which can measures frequency, which device which vibrates. A smart peg sensor is mounted on top of the implant, and the sensor is then brought towards a vibration towards the implant. The vibration may by gentle moving it with the magnetic pulses. The sensor will vibrate for a short while and then stops. If the implant stability increases, the vibration frequency of the sensor will be increased. So this is how the ISQ value can illustrate the primary stability. ISQ value less than 60, it has a low stability. The medium stability will have ISQ value between 60 to 70. Highly stable implant shows ISQ value of more than 70. The role of primary stability for a successful immediate loading of a dental implant, a literature review from the Journal of Dentistry. Objectives. To assess the role of a primary stability for a successful immediate loading of a dental implant, the original articles studying the role of primary stability for a successful immediate loading of a dental implants were included. Results. There is a significant biological response by the hard and soft tissue to implant loading of a dental implant. Within a limitation, within the limitations of the present literature review, it is evident that the core issue to observe during immediate loading is to establishment of a good implant primary stability. There is a sufficient evidence to suggest that the degree of achieved primary stability during the immediate loading protocol is dependent on several factors, including a bone density, a bone quality, a implant shape, implant design, and the surface characteristics and the surgical technique. A diet is another important factor when it comes to immediate loading, because you're allowing a patient to have their normal meal soon after the surgical protocol. So you should always advise a patient to go with a softer diet in the beginning, and then later on eventually you can shift to normal diet. And also, which is we normally make a diet chart for the patients soon after the protocol. We should always recommend the patient to go with the nutritional food with a highly protein diet for the better metabolism and better integration of your implant. Risk of immediate loading. Let's see what are the risks. Early crestal bone loss after the implant loading may have a relationship to occlusal overload. The early loading was speculated to interface with the ability of necrotic bone to be replaced by a newly formed bone. A successful implants with a greater than 5 mm soft tissue pockets may be more often results of immediate loading. In the immediate loading technique for a completely edentulous patient, more implants usually are inserted, which increases the fees and makes the patient acceptancy less likely because of the economic factor. Implant failure may increases the malpractice cases against the dentist, especially because the patient may need to wear a removal processes and may be subjected to several additional surgeries and then appointments. Split and surgical appointments from the prosthesis delivery appointment. So when you think of immediate loading, there will be two appointments. One would be surgical and followed with the prosthetic appointment. Place the implants and make an impression on the same visit. In addition, the dentist records a vertical occlusal at dimension, vertical dimension at occlusion and centric bite has been registered. The bite registration may be made with the shell of transitional or transitional restoration on an abutment or with the base plate on a wax rim. The laboratory posts the impressions and select and prepares the abutment for the restoration and fabricate the transitional processes. Then at the suture removal appointment at 7 to 12 days later, and you can also deliver to think of transitional fixed processes. After healing 4 to 8 months, the transitional restoration may be cut off and then the final process is being given. And next 1 hour, you'll be able to go through your laboratory procedures, how it's been maintained in full mouth rehabilitation. Review of literature. Immediate versus delayed function loading of an implant in the posterior mandible. 2-year prospective clinical study of 12 consecutive cases aim to evaluate the clinical success of an immediate loaded implants versus implants loaded in a delayed fashion in the posterior mandible. 3 implants were placed, distal to canine, bilateral in the edentulous distal mandibular ridges of 12 patients. Results: 29 of the examined sites showed no bone loss after 2 years of loading in the posterior mandible. Test and control implants had the same prognosis. Changes in alveolar bone density around the immediate functional and the non-functional loaded implants. Aim to quantitatively assess the radiographic changes in an alveolar bone density around the immediate functional and non-functional loaded implants. Materials and method. A prospective longitudinal study was conducted in which 20 participants with the partial edentulous mandible received an implant that were immediately loaded, either functionally or non-functionally. Standardized intraoral periapical radiographs were made at baseline 3 to 6 months. Results: immediate loading of implants helps to stimulate the bone ossification around the implant at a lateral apical level and the crest from 3 to 6 months. Furthermore, the immediate functional loading of an implant resulted in a significantly greater degree of bone demineralization at the alveolar crest from the time of implant placement up to 3 months compared with immediate non-functional loading. Conclusion: patient care requires implants to restore a function, aesthetic, harden soft tissue contour, speech, and intraoral health. In some patient conditions, the delayed healing process can cause a psychological, social, speech, and functional problems. Immediate restoration of a patient after a surgery is one of these alternatives. Careful patient screening and selections are required when an immediate implant placement with the immediate loading procedure is a treatment consideration. Patient screening means, I mean to say, whenever there is a patient walks into your office, you always screen the oral cavity and you take the medical history of the patient. Thorough medical history, medical examination has to be given, and you record all the medical history of the patient, and then you take a photograph, intraoral photographs, so that this can help you in absence of patients. It can give you all the guidance how we can do for your furthermore planning of your immediate loading. And then you scan the patient, you send the patient for the scanning and the biological investigations. When the biological investigations should always write a prescription for the complete CBC and the coagulation test, and for the serum glucose, serum cholesterol, serum creatinine, and the serum urea and uric acid. And also we write 24 hours urine calcium so that it can give you complete calcium phosphate metabolism of the patient. And also the diagnostic cast is very important to evaluate the evaluate the jaw relation, the class 1 class 2 relation between the maxilla and mandible. These are the references which we've been which have taken from various references which have taken for the immediate loading concept. So let's see the cases we've been doing of late since a couple of years, the immediate loading. So this is the patient of age 61-year male patient came with this kind of a condition wherein a lot of more than 10 uh, more than 10 problems like a lot of root stems, root caries, and missing teeth, occlusal missing. This is the condition from left lateral view. This is the right lateral view. There are a lot of root stems. So this is the occlusal view showing a lot of root stems and a decayed tooth. And this is the mandible, complete loss of posterior teeth, and symphysial region. There are some root stems which are left, which is also showing a superiorly erupted alveolar bone. On the right side, there are some root stems. We intend to extract these root stems, and CT scan, CBCT cone beam shows a huge periapical lesion at the premolar region. We extracted it. We extracted all the root stems, and we did a thorough debridement at the premolar region with the solutions gentamicin, metronidazole, and 1:1 betadine solution. And this is a solution we use it for any infective surgical site. To before we think of any surgical protocol, we thoroughly debride the area with an antiseptic solution. And we selected some of the good bone island, and then we went ahead with the implant placement. So this is on the left hand side of the patient, second quadrant, where we had canine was a root stem, and premolar was edentulous area. Again, we had an adequate amount of bone there. And this is the placement of implants and maxillary arch. And we also restored with the filling of anterior teeth, and also we did the devitalization of the posterior teeth by doing root canals. And then we gave a temporization for the maxillary arch. And then we went with the mandibular arch. And mandibular arch, there was a root stems. We extracted them, and there was a superiorly erupted alveolar bone. I don't like to lose any kind of a bone like this. In implant, every bit of bone is very very important. But wherein we didn't have any intention to use this alveolar bone anywhere in any other surgical site, and we trimmed the bone with a long shank diamond burr. We created a proper osseous bed with the occlusal plateau, and this is what is created after the trimming of alveolar bone. And this is a proper occlusal plateau with the occlusal osseous bed. And we went ahead with the implant placement. We placed 8 implants. Along with that, we gave multi-unit abutments. And this is the hermetic closure after placing the multi-unit abutments. And this is the impression coping for the multi-unit abutment. We placed all the impression coping for the multi-unit abutment, and also we take a radiograph to ensure that your multi-unit abutments and the multi-impression copings are engaged in a perfect manner. And they're all splinted with a Teflon tape so that they don't move. You splint all the impression coping, and over this I normally use Luxabite. It takes almost 90 seconds to set, and once it's set, it becomes really hard so that it does not allow any of your impression coping movement in the oral cavity. And then impression has been taken, and then we place the multi-unit abutment healing collars. And this is how the impression appears, and this is the one with the lab analog, and this is the now some of them which I wanted to show the image of this multi-unit abutment impression coping, how they appear from inside. And this is the lab analog which will be engaged to impression coping. And this is the castable cylinders which is come as a jig trial on the patient cast, laboratory cast. And then we try in the patient mouth. We have a passive fit on all the multi-unit abutments. And then we went ahead with the casting the bar. And after casting the bar, then we made denture out of it. And then this is how it appears from inside. And then we give him a final processes. And this could be interim processes. I would give him these processes maybe probably 6 months to 2 years time. And when he's ready to go with the final processes with the ceramic, So we change this hybrid denture from hybrid denture to final processes with ceramic. So let's see another case. Another male patient of 52-year-old wanted to was looking for a quick fix because he had come from overseas, and he had a very short duration of stay in India, and this is how he came to our office, and then we took some images, and it shows occlusal images like which these are the remaining tooth which are also showing kind of a grade 2 mobility, and we went ahead with the extraction of all the teeth, and we did the debridement of a soft tissue again with the same gentamicin, metronidazole, and the betadine 1:1 solution, and we remove all the encapsulated fibrous tissue, and then radiographic view showing 8 implant placement in alveolar bone. We had luckily, fortunately, we had an adequate amount of height and width in these kind of cases. And this is how the multi-unit abutment been placed. And this is the multi-unit abutment healing collar. And some company comes with the plastic sleeves, some company comes with the metal sleeves of the healing abutment. And this is the jig trial, just to ensure your impression is gone perfectly right. And this is the immediate denture was given for the patient, and then this is the occlusal view on the right side. So let's move on to another case when this is a female patient of age 60 year. We when we saw the scan, we could observe something in a huge polyp in the maxillary right sinus. So we could have also thought of giving a all on four kind of a situation here because there is a cantilever bridge uh, FPD is given, and there is a residual bone height is very minimal, but the bone quality was not that good enough to think of that, and also the remaining tooth were also showing a kind of mobility. So we open up the we approached the direct sinus grafting. We give a nick at the base of the polyp, and we drained the polyp out, and then we did the elevation of my mucosal lining, and we did the grafting, direct sinus grafting on bilateral side, and then we removed the remaining tooth, and then we went ahead with the implant placement, and still we gave again a multi-unit abutment, and she was very keen on saving one of her natural teeth, though it has got a decay and filling, so she was very keen on saving it, so we said okay fine, let's go ahead with saving that tooth. And then we made an impression with an impression coping. Here we've used multi-angled abutments in the anterior so that to prevent the screw hole axis coming on the label side of the veneers. So we didn't want it to spoil the aesthetic purpose of it. So we gave a multi-angled abutment. And this is the Luxabite, which has been put on the plumbing tape on all the impression coping, and this is stabilizes all the impression coping by holding on to each other. This is how the impression appears. This is the jig trial done. This is the immediate processes was given, and then later on after 6 months we went ahead with the fixed. She wanted fixed processes with the ceramic material. We did a milled CAD/CAM abutments, and we did the jig trial of the CAD/CAM milled abutments. And this is how the appear of the patient in the intervally. And this is interval picture of a processes. This is occlusal view of the left side. This is occlusal view of the right side. This is occlusal view. Let's move on to another case. Another 58 years old female patient kept on breaking her denture quite oftenly, and she didn't know what was the reason, but like she had a lower natural dentition, and she was a bit upset to use a denture anymore, and she wanted something fixed solution. So we took a scan, we did all the blood investigations, and all the after a thorough investigation, we went ahead with the surgical protocol. We give a full thickness mucoperiosteal suture incision. We raise the flap, mucoperiosteal flap, and we gave a stay suture at the palatal soft tissue, palatal flap. And also, I prefer to give buccal and labial stay suture, so that you don't have an interference of your flap falling on a surgical site in, time and again. These are all the 8 implants placed. This is implant level impression. We placed a open tray impression coping directly onto the implants, and then we made an impression, and this is the healing color for the second day. And closure is being done with the Prolene suture 50. And this is how the radiographic view of all the 8 implants in the place. This is how the impression coping been splinted together with the luxabite material. Occlusal rim to take a jaw relation for natural dentation towards edentulous implant arch of the maxilla. And then the casted bar. This is fitting on the laboratory cast, and then we try it in the patient mouth, which has a passive fit. We went ahead with the hybrid denture with this patient. This is how the patient appears with the prosthesis. This is the picture I wanted to show you. If you are not been if you are not been able to take care of multi-angle department or the placement of implant towards the palatal aspect, this is how you can see screw hole axis coming onto the labial side. So your winnering is been which is anesthetic. So if in this kind of condition, so you can always use a composites to mask this screw hole axis. Another case, edentulous patient on the upper arch, and the lower arch is completely loss of alveolar bone. She was using a denture for the maxillary arch, and she was also using a denture for a mandibular arch. But since there was no alveolar bone, there was no retention absolutely whatsoever, and she was a bit upset to use the mandibular denture. She was looking for something fixed for the mandibular denture. So when we evaluated the mandible, so there was a complete loss of alveolar bone, and this is how it appears in the radiograph. And you can see a small elevation of bone in the canine region, and we trim that alveolar bone to make a proper occlusal plateau of the osseous bed. This is the radiographic view, and this is how been planned for all and four in this case, because the inferior alveolar neurovascular bundle, it is the superior most position, so we can't think of any endosseous implants, or I mean, sorry, the posterior implants. So we can only think of tilted implants in this kind of situation. We did trimming of osseous bed here. We made a level occlusal plateau of mandibular complete alveolar bone, basal bone. We placed 4 implants. 2 of them are straight in the anterior region, symphysial region, and 2 of them are tilted implants at the premolar region. This is how the mount looks like, and this is the healing cap. After the implant placement, till we pick up the impression, we had to keep the healing collar so that the soft tissue encroachment will not be there towards shrinkage towards implant. And this is the metal cylinders has to be kept on the multi-unit abutments, and then to pick it up from a patient denture. And then this is how the radiograph. This is how the metal cylinders are picked in a denture, and which are cured them with the cold cure material, and they are fixed onto the denture. And then this is how it appears after polishing. We have used the patient denture itself to pick up the metal cylinder from the impression coping, and this is how it has been placed on the same day. And upper has a denture, and lower are all with the all on four implant processes, and it's been fixed to the patient. And this is occlusal. This is how she appears. Another final case. In this case, we have used, luckily, we were introduced by iFix implants on the wonderful system. And this is the patient who is also a female patient of 62-year-old, having a lot of multiple problems in her oral cavity. All of the teeth are decayed and grossly decayed, seeking for all the endodontic treatment for all the remaining teeth. And our lower arch is completely edentulous. Some of the teeth are also having a periapical lesion, and we went ahead with the proper endodontic treatment. After endodontic treatment, we have taken a picture to prep the teeth, for fixed processes. And when we were doing a fixed processes, we could notice that second quadrant label aspect was little placed on the buckle side. So we evaluated, we had to correct that part, and then we corrected. After the correction, we give a processes, and it appears like this. And this is how the radiographic view of fixed crowns and endodontic and implant placement in the maxillary arch at the posterior region, and implant placement of mandibular region. This is how the iFix implant appears in the radiographic view, and this is what is picked of immediate pickup in the with the impression coping, and a denture was used to give a fixed processes immediately on the second day, so third day of the surgery. This is how the occlusal view is given, and this is how she appears. Thanks to these iFix implants, which has been a boom for Indian market. Luckily, fortunately we have our own country implant been introduced by iFix, which is has all the qualities when you compare with any other implant system, which has adequate micro threads and macro threads, and depth between the pitches, and the threads are parallel, which are meant for immediate loading. We have used all this implant. I mean, we've used iFix implants in all the case scenarios like rid split, maxillary sinus grafting, immediate loading, immediate placement, which has been given a phenomenal result. And it's good. I mean, when it compares off late now, we've been having a lot of issues with Korean implants and Israeli implants and European implants. Of late, they've been winding up from country, and we are left with a lot of components, and nobody's taking it. So fortunately, we have our own country implants, which mean, uh, they assure you kind of service, or if they're open for all your queries, and the problems which you come across, you can always acknowledge to them. So that is one thing I would like to thank iFix implant for that. Thank you for giving me this opportunity. I thank DRDCA 2020 for doing the phenomenal job and giving me this opportunity to speak on this podium. I thank a lot to the entire Congress committee. And this is my email ID. If any queries, please, you can always write, and I'm open to question and answer, please.
Thank you, Dr. Prem Kumar Kariyappa. Thank you so much. Albert Einstein said that the only source of knowledge is experience, and you need experience to gain wisdom. So thank you so much for sharing your wisdom with all of us. Because like I am an endo, I am not doing many cases like this, but yes, when if somebody asks me about immediate loading of edentulous patients, so I'll say that yes, that is possible, and I think I am going to get back to this again. Thank you so much, sir. Thank you so much. Shall we go ahead with questions?
Yeah, please. You're most welcome for your thanks, and go ahead with the questions. Yeah.
Thank you, sir. Sir, when do you know when to go for all on four or all on six, and when to go for conventional full arch implants?
Okay. Good question. See, you need to analyze the scan, wherein if you have inadequate bone up to second premolar, your sinus is encroaching, so you can think of going for an all on four. Suppose if you're at the posterior region, if you have a good height of alveolar bone, you can always think of all on six, all on eight, in that kind of cases. Where you have only bone, a good amount of bone in the premaxillary region, you can think of all on four. Suppose if you don't have a adequate amount of bone in the premaxillary region, you can always think of going for a zygomatic implants. But I always normally prefer all on six, all on eight. This would be my ideal prefer. But depending on the situation, depending on the case, it all depends on the case to case. So you need to evaluate the scan. Where is the availability of bone? To what extent you can think of going for an implant placement?
Okay, sir. How to take impressions in full arch implant cases? Just the
Okay.
yeah.
It's either you can go with the conventional technique. Now you have a digital scanner, which is a very boom. It's a very good advantages when it comes to full arch. one who doesn't want to take a full arch with a digital impression, we can always think of making a special tray. You can always make a custom tray and take an open tray impression coping, open tray impression technique. So that is how we can take a full arch impression. But nowadays, you can always approach a laboratory to help you with the scanner. Scanner gives you more accuracy in that. Scanner gives you more accuracy in that.
Okay, sir. Another question: it's related to iFix implants that you mentioned. Are
Yeah.
iFix implants comparable to Sive or other standard implants? I'm not sure if I
I
pronounced.
don't like to compare iFix implants with any other implants. It has its own unique feature, and iFix is iFix.
Since
Or
how long have you been using them, sir?
I've been using it since 2019 November.
Okay.
We have used in many cases. Yes, of course. We need a follow up. We need case study as well. It takes a long time. Yes, of course, we need to give an opportunity to
Right, sir.
study their
I think
quality. Of course,
local. Yes.
yeah, we have used Xi, we have used Ankylose, we have used Noble, a number of implants, but like in that's nonetheless, iFix implant also has a very good future in our country compared with any other European system or a US system.
Okay. So one user has asked about zygomatic implants demo. I'm not sure what the question means.
Demo we cannot give you on this, but like in yes, we can do a zygomatic implants, we can do pterygoid implants, we can do a transitional transmucosal implant, and a transosteal implants are there. There are various different techniques depending on the bone availability. Yes, it is a different surgical technique. You need to have a extra surgical skill to place the zygomatic implants. It probably we can show a video or maybe we can show a live surgery when it comes next when we get an opportunity
Sure.
to place zygomatic implants or a pterygoid implants.
Right, right. Another question, sir. In all on six implant cases,
Mhm.
do we need to place the implant parallel to each other?
Of course, of course. If you're placing six implants, eight implants, they all need to be parallel to each other. All need to be parallel to each other. There has to be minimum of 3 millimeter space between the each implants, which is very essential.
Okay. Another question about guided implants.
Mhm.
Disadvantages of guided implants.
Guided implant is good, provided if you are intact with your skill of placing an implant in the alveolar bone. You develop your own skill, and one fine day you start using a surgical stent. Surgical stent is it gives you more accuracy. It gives you more accuracy, and you know where you're going, and you know where you're placing an implant. Though you cannot go wrong whatsoever reason. Whereas without a surgical stent, yes, you have your own tactile sensation to place implant. Yes, I mean both has its own advantages and disadvantages. A surgical stand and without a surgical stand, it has its own advantages and disadvantages.
Okay,
I would,
sir.
in case of beginner, I would recommend to go ahead with the surgical guide.
Okay, sir. So another, since we were talking about edentulous patients, so there's a question in which the doctor has asked that a patient specifically has lost all the tooth, only molar, third molar is. So is it advisable to take the support and give basal implants?
That's a different technique. Basal implant is a different technique altogether because basal implants are basically they are engaging with the cortical. We in endosseous implants we place an implant within the endosseous of the bone so that there is a bone turnover and there is the bone width is maintained. Whereas in basal implants they are engaging with the basal bone and they get the primary stability from a basal bone or a cortical bone. Yes, it's a different technique, different implant design, bit different technique, and different approach altogether.
So those were the questions, sir. Thank you so much, and
Thank you.
thank you for this, because I think sharing the theoretical knowledge and when you see the cases, it makes a whole lot of difference that we know that
True,
something can be done. Thank you so
true.
much. It was an honor to
You're
have
most,
you.
You're most welcome. Most
Yes,
welcome. And thank you so much for giving me this podium to speak on DRDCA 2020. And I wish you all the best for the future scientific session. Thank you so much.
thank you, sir. Thank you. So that was Dr. Prem Kumar Kariyappa, who spoke about immediate loading in Edentulous patients. I can see there's one question that has popped up just now. So if you have any questions, you can find the contact number and details of the speaker on the app that I mentioned that you need to download for event page, and you can see the details of the speaker. You can directly contact them, or you can contact us. You can send us drdca2020 at the rate of gmail.com. You can send your query and we'll try to put it forward to the concerned speaker and find you your answers. So in case you have not downloaded, please download and register for the conference. Few days are left, and you can miss 40 CD points, certificate of participation. But having said that, I hope you guys are listening to the scientific sessions, because to be honest, I am learning a lot of things. So yes, talking about the next speaker, we have Dr. Surabhi Mahidhar with us. He's a prosthodontist. He's going to speak about diagnostic mounting in FMR cases, full mouth rehab cases. So Dr. Surabhi Mahidhar has done his master's in prostho and implantology from JSS Dental College and Hospital, Mysore. He has also done his fellowship and mastership in surgical and prosthetic implantology from Bangalore. He's a former professor. He was a former professor. He has been professor at Shamla Reddy Dental College, Bangalore. Dr. Mahidhar has conducted many workshops and courses in prosthodontic procedures and is a recipient of multiple national dental awards like International Dental Excellence Awards 2018, Indian Health Professional Award 2018 for Best Prosthodontist of the Year 2018. So yeah, without any, he's into clinical practice from 2008 after post graduation, and has been lecturing all over the country on various aspects of FPD, FMR, complete dentures, and implant prosthetics. Again, the questions, you can ask your questions in comment section. Put in questions as you are listening to the lecture, so that we have ample number of questions in the end, and that lag is not there. So yes, keep listening, and I welcome Dr. Surabhi Mahidhar. Doc, screen is yours.
Thank you so much for the wonderful introduction, Dr. Pallavi. And thank you for having me here to speak on one of my favorite subjects, full mouth rehabs. When it comes to the diagnostic mounting, especially, it is one of the most important, one of the most neglected aspects of full mouth rehabs. So I thought, why would not I present something on this interesting as well as important topic today. And it's a wonderful initiative by all of you guys. You're doing great job here. And without wasting much time, I would go into the session straight away.
Yes, yes, we can see the screen, sir.
Thank you so much. Is the screen clear now?
Yes, it's clear.
Yeah. So greetings from India. This is Dr. Surabhi Mahidhar. I am a prosthodontist as well as an implantologist. I've finished my PG in 2008 from JSS Dental College, Mysore, and from then I've been into private practice. Today, my topic is about diagnostic mounting. If you see here, I've kept two symbolic representations of diagnostic mounting. So when I say mounting, let's see what exactly is mounting. What exactly is the difference between your mounting and diagnostic mounting? So when I speak about mounting, the first thing what we understand is we are taking a maxillary cast, we are taking a mandibular cast, and then putting them onto an equipment which is similar to the oral cavity. Okay, so we'll see what is that equipment in the further slides. But as of now, we should understand that mounting is nothing but we are arranging the maxillary and the mandibular cast in a spatial relationship against each other in a specialized equipment outside the oral cavity. There are different kinds of articulators, which I mean to say it's a specialized equipment, which is similar to the oral cavity that are there in the market, available in the market. We'll see each articulator and how it functions like. So what is basically mounting is we are taking the maxillary and mandibular cusp and putting them on this specialized equipment, which is known as articulator. The first thing what we have to understand is when we talk about articulators, articulator is nothing but an equipment which is similar to the oral cavity. It is similar to the stomatognathic system. It has an upper member, it has a lower member, which simulates the maxillary and the mandibular members in the oral cavity. So we can attach the maxillary cusp to the upper member, we can attach to the mandibular cusp to the lower member, and then we do a procedure which is known as mounting. If you see this picture in particular, this is known as the hinge articulator. We don't use this articulator anymore. This is a very basic form of articulator which has only the upward and downward movements when it comes to its members. So it's only the static movement that happens with the articulator. We don't have any dynamic movements. So in case of any case which is related to the full mouth rehab, in case of any case which is related to a stomatognathic equilibration, we need to have an articulator which has static as well as dynamic movements. That's the first point we need to remember. So we don't use this anymore. Then comes your mean value articulator. This also has only the static movements. A freedom of dynamic movements is there, a little freedom of dynamic movements is there, but still we do not use this articulator also when it comes to full mouth rehab, because we don't have the freedom of the dynamic movements, especially the protrusion as well as the right side and the left side lateral protrusion. And then comes your semi-adjustable articulators, which are widely used when it comes to the full mouth rehab cases or any case of equilibration. Let it be a rehab, let it be any case of stomatognathic equilibration. We use this semi-adjustable articulators where it has a freedom of static as well as dynamic movements. Let it be an opening and closure, let it be protrusive, let it be the right and left lateral protrusive movements. We can use this semi-adjustable articulator when it comes to a full mouth rehab case or any kind of equilibration case. Then comes your fully adjustable articulator. The only difference between semi-adjustable and fully adjustable articulator is the condylar track. So when I speak about condylar track, every one of us has a condyle and glenoid fossa in which the condyle travels whenever we are moving, whenever we are doing any kind of movements with the jaw. So the same simulatory movement is there in your fully adjustable articulator. The same shape of the glenoid fossa is simulated in a fully adjustable articulator, whereas in case of semi-adjustable articulators, you have a straight track of condylar fossa. You don't have this the fossa shape which is there anatomically in the human skull, but there is a straight track that is present in a semi-adjustable articulator. That's the major difference between semi-adjustable and a fully adjustable articulator. The fully adjustable articulator is usually limited to the academic purposes. We don't usually invest on fully adjustable articulators when it comes to the practices, the general practices as such. So the widely used equipment or the widely used instrument when it comes to your full mouth rehab cases is your semi-adjustable articulator. That's the first point which we need to remember when it comes to the mounting. The second point is which is the cast that is first mounted. The cast which is first mounted is your maxillary cast or your upper cast. So can I use my hand to take the cast and mount on a semi-adjustable articulator? Can I randomly carry the cast and then mount it to the upper member of the semi-adjustable articulator? No. Why? Because when you see the anatomy, when you see the stomatognathic system as such, the maxillary bone, the maxilla is attached to the skull in a kind of spatial relationship. So it could be canted, it could be straight. I don't know in which spatial relationship this maxilla is attached to the cranium in particular case, in a respective case. The maxilla could be anteroposteriorly canted. The maxilla could be laterally canted. The maxilla could be straight attached to the cranial base. So according to each patient, you have a spatial relationship of maxilla with regards to or in relation to the cranial base or the skull base. We need to capture the same spatial relationship and then transfer it onto a semi-adjustable articulator. If not, If I just take my hand, carry it in my hand, and then just attach it to a semi-adjustable articulator in any of the relationships I want, when it comes to the upper member of the articulator, this cant would be different from the cant that is present inside the oral cavity. So that's the second point which we need to remember, that maxillary mounting on a semi-adjustable articulator should not be done randomly. We cannot just take the cast in our hand and then put plaster over it and then mount it on a semi-adjustable articulator when it comes to the upper member. So how should we do? We have a specialized equipment which is known as a phase bow, which is used to capture the spatial relationship of the maxilla in relation to the cranial base, and then we carry this phase bow record and then mount it on a semi-adjustable articulator. So what does this phase bow do? The phase bow captures the maxillary cant as it is, that is present inside the oral cavity with respect to the cranial base. So it takes the reference points on the face three-dimensionally. We have two reference points posteriorly, which are your external auditory meatus. There are a few anterior reference points also, which could be your nasion, which could be your infraorbital notch or the orbital. So it captures the maxillary orientation when it comes to the skull base or the cranial base, takes that orientation, puts it on a semi-adjustable articulator in the same way that is present inside the oral cavity. So what are we doing? We are just capturing the cant of the maxilla, putting the same cant on a semi-adjustable articulator, so that my final restoration would be having the same cant that is present inside the oral cavity. If I don't do this and randomly mount the maxillary cast on a semi-adjustable articulator, what would happen? The final restoration would be having a different cant. And when I take this final restoration, keep it inside the oral cavity and then tell the patient to bite on it, we would see interferences that have crept in. We would see a lot of high points in a layman terminology that would be there on the restoration, final restoration. We don't want that. So we need to capture the same cant that is present. We take that cant, we put it on a semi-adjustable articulator, and then we finally prepare or fabricate the definitive restoration, which would not have interferences to a certain extent. At least we would be avoiding it to a certain extent. So we have phase bows in the market. We have different kinds of phase bows. Whichever is convenient, we can invest on. We have Artex, we have different kinds of Hanav, Whipmix, BioArt, CSA, different types of articulators, different types of phase bows. According to our practices, according to our convenience, we can invest on something, and then we have to start incorporating taking a phase bow transfer for full mouth rehab cases. That's the first point I want to convey here. We also have other instruments which are known as dentofacial analyzers. These are different from phase bows. These are a simple and almost accurate equipment that we use in our practices. These are known as DFAs, dentofacial analyzers, that we can use it in our practices and then capture the cant or the orientation of the maxilla in relation to the cranial base and then transfer it on to a semi-adjustable articulator. And once the mounting of the maxillary cast is done on a semi-adjustable articulator, which are different types again in the market, you have BioArt, you have Artex, you have Hanav, Whipmix, CSA, CSA 400, CSA 600, whichever is convenient to you, whichever is feasible, you can invest on it and keep it. So what we understand from these basic slides: stop using your hinge articulators. Stop using your mean value articulators for full mouth rehab cases. Start using phase bows. Start investing and using semi-adjustable articulators in practices when it comes to the full mouth rehab cases. So once we are done with the maxillary cast mounting, so each articulator has a specific mechanism of mounting the maxillary cast. Here I am showing you a CSA articulator which has a mounting jig which can take the phase bow transfer, and then you can mount the maxillary cast onto the upper member of the semi-adjustable articulator. But it is not generalized. It is specific to the system which you are using. It is specific to the articulator which you are using. You can invest on the specific articulator, and then you can mount it according to the specifications that is given according to the articulator you use. And once the mounting of the maxillary cast is done, The next thing what we need to understand is we need to take the mandibular cast and mount according to the maxillary cast, which is already mounted on semi-adjustable articulator on the lower member. Here you have to understand two different relationships that exist inside the oral cavity. The first thing is your maximum intercuspation, and the second thing is your centric relation. If you see here, I have mentioned it as ICP. What is ICP is intercuspal position. When it comes to position, it is the position in between the teeth. The maxillary teeth versus the mandibular teeth in maximum intercuspation. When the teeth guide the position, if I open up and just close, now the teeth are guiding the position here. It's not related to anything else. It's just the teeth that are occluding against each other. And that position is known as your ICP, or it is also known as maximum intercuspation. It is not necessary that always my maximum intercuspation is equal to the centric relation of the joint. When I speak about centric relation, it is not teeth guided. That's the first point. It is always joint dictated. What is the joint that we have in the skull? It is the temporomandibular joint. So when you take temporomandibular joint as such, you have condyle, you have glenoid fossa, and you have an articular disc in between. The relationship that is existing inside the glenoid fossa, when all these three components are in a state of equilibrium, in a state of comfort zone, in a state of a happy state, in a state of a happy functional state, then yes, you can call that relationship that is existing inside the joint as your centric relation. So when I bite on my teeth, it is not necessary that now the teeth are biting against each other or occluding against each other in centric relation. The joint might be in a different state. All right. So joint position is different. Teeth position is different. They are not equal to each other. They might be equal to each other. We don't know what is happening inside the joint. I cannot open up the skull, see whether the condyle is in centric relation or not. I cannot do it. What exactly I can see? Whether the teeth are occluding against each other. And that position is known as maximum intercuspation. And what is happening inside the joint, irrespective of the teeth, is known as centric relation. So the first point what we need to understand is when we guide the jaw without the influence of teeth, we can achieve centric relation. When we guide the jaw with the influence of teeth, we might not achieve centric relation because the teeth are guiding here and the condyle could be in a different state, could be in a different position than your centric relation inside the glenoid fossa. But when I take away the teeth against each other and then guide the jaw freely in a hinge movement, then I can achieve a state of equilibrium inside the joint, and that relation is known as centric relation. That's the basic difference between your maximum intercuspation and centric relation. If you see these two slides here, this is of the same patient and this is also of the same patient, where we see two different pictures here. This is in maximum intercuspation, where you have complete intercuspation that is happening. There is occlusion that is complete here. But when I guide the jaw into centric relation without the influence of teeth and then close the jaw against, close the mandibular jaw against the maxillary jaw, if you see here, there are some spaces that have crept in anteriorly. There is only one tooth probably somewhere touching in the posterior area, and that tooth which is touching is known as your first point of contact. That is also known as retruded contact position. So in centric relation, where I am taking the joint into a state of equilibrium, into a state of functional comfort zone, and then guiding the jaw into the CR, centric relation, it is not necessary that this picture is seen where you have maximum intercuspation. Most of the times we see something like this, where there could be one point of contact here or 2 points of contact on either sides of the arches. There could be multiple points of contact also, but it would not be in maximum intercuspation. There is some point of contact which is known as first point of contact, which is acting as an interference in between the maximum intercuspation and centric relation. Okay, so this is the basis now. The interference that is existing in centric relation is the basis of any kind of equilibration case. If we eliminate this interference, which is happening in centric relation, then the jaw slides into maximum intercuspation. The interference is eliminated, then CR becomes equal to maximum intercuspation. And this is the final goal or the final aim of any kind of full mouth rehabilitations. So what is full mouth rehabilitation now? Full mouth rehabilitation is nothing but interference-free occlusion. And what is that interference? That interference is your first point of contact or recruited contact position in centric relation, which we are guiding. We are gently guiding the joint to centric relation, finding that first point of contact or interference, and then starting to eliminate it or avoid it so that now my centric relation is equal to the maximum intercuspation in the final restoration or definitive restoration. That is known as equilibration. That is known as your full mouth rehabilitation. Is it easy for me to find this interference inside the oral cavity? If you see the second picture here, can I put my head inside the oral cavity and find out which cusp has this interference? Can I see easily which incline on the cusp has this interference, whether the functional cusp has, whether the non-functional cusp has, whether the mesial incline, distal incline, buccal incline, palatal incline? Can I find it out? It is not easy. I can find it out with occlusal indicators. I can use some articulating papers and then find it out. But it is difficult because we have cheeks around, we have lips, we have tongue, we have saliva. So everything is acting as an interference to find that interference inside the oral cavity. So what can we do? We can just take this maxilla out. We can just take this mandibular arch out in the form of maxillary and mandibular cast respectively, put them on a semi-adjustable articulator in centric relation, and then find that first point of contact. Easy. No cheek, no tongue, no lips, no saliva, no messy work. So we can easily find it inside on a semi-adjustable articulator rather than finding inside the oral cavity. And this process of taking the maxilla, mounting on a semi-adjustable articulator, taking the mandible and mounting on a semi-adjustable articulator with centric record is known as diagnostic mounting. So let's see how we do it. So this is your normal mounting where you have maximum intercuspation that is happening here. Why do we do this normal mounting without centric relation? It is just to find how the teeth are against each other inside the oral cavity. In my normal maximum intercuspation, I can just see what is happening inside the oral cavity in maximum intercuspation. If I have any kind of tilts, if I have any kind of supraerupted teeth, if I have any kind of rotations, how many number of teeth missing, number of edentulous spaces, all these things, instead of seeing inside the oral cavity, if I mount this way on a semi-adjustable articulator in maximum intercuspation, I can note down the details well in a very precise manner. That's why we do what is known as mounting in maximum intercuspation if we are conforming to the occlusal scheme that is present inside the oral cavity. Suppose I am doing minor restorations. I am not changing the occlusal scheme here. I am doing one crown over a tooth. I am not changing any occlusal scheme here. I am conforming to whatever is present inside the oral cavity, whatever occlusal scheme that is there inside the oral cavity. Then this is known as confirmatory approach. And the mounting that we do in confirmatory approach is known as mounting in maximum intercuspation. We are not doing any changes to the occlusal scheme that is present inside the oral cavity. We're just confirming to whatever is present. So this is the first thing we need to remember. This is known as diagnostic mounting, where we mount the mandibular cast against the maxillary cast with a centric interocclusal record. If you see here, the blue thing that is present, that is your centric interocclusal record. We guide the jaw into centric record, a centric relation, pardon me, and then take a centric record in between the maxillary and the mandibular jaws. Mount the mandibular cast against the maxillary cast with the centric interocclusal record. When do we do this? If you see this picture, what did I say? I said that we are conforming to whatever is present inside the oral cavity and mounting. Here, we are not conforming to whatever is present inside the oral cavity. We are reorganizing things. The occlusal scheme which is present inside the oral cavity might be harmful. It might not be suitable to have a equilibration inside. So in such cases, we might have to reorganize the occlusal scheme, and this approach is known as reorganized approach, where we are taking a centric record, finding that first point of contact, and from that first point of contact, we are actually going for a treatment planning. We are diagnosing the first point of contact, and then we are going for a treatment plan of stomatognathic equilibration. So let's see all those things in a sequence. So how do I get the centric record? I said maxillary cast is already mounted with a phase bow record. So we take a phase bow or a dentofacial analyzer, we capture the cant of the maxilla, we capture the orientation of the maxilla, take this maxillary cast and then mount it on the upper member of semi-adjustable articulator with a phase bow record. That is done. Now, how do we take the centric record is the next question. Let's see. For that, we need to have a sequence that needs to be followed. Centric record is not a random thing. It's not just we just need to guide the jaw into a posterior position and then take a record. No, absolutely not. There is a sequence for it. If you see this picture, you will basically understand that the evolutionary process has come down. It's not like this. It's like this. So the first part that's formed is your cranium, and then the glenoid fossa, and then your mandible, maxilla, the jaw structures, and then finally the teeth that are there inside the sockets. So if the evolutionary process has come down this way, we need to respect that. We need to respect the direction of evolutionary process. So whenever we are dealing with any kind of stomatognathic equilibration case, whenever we are dealing with any kind of full mouth rehab case, we also have to follow this direction. What do I mean by this? What I mean by this is the first part that is formed in the stomatognathic system is your TMJ, the temporomandibular joint, and then your muscles that are surrounding the stomatognathic system, and then finally your jaws, and then the teeth that are there inside the socket. Suppose we have a full mouth rehab case. I've prepared all the teeth. I have not taken my temporomandibular joint into consideration. I have not taken my muscle into consideration. I just keep restoring the teeth. Put partial bonded restorations or full crowns on the teeth inside the oral cavity without taking the TMJ and muscle into consideration. Am I justifying it? No. I'm not doing any kind of justice for such cases because I'm not following the order here. What is the order? First, I need to evaluate the TMJ, I need to evaluate the muscle, and then probably come on to the teeth and do the restorations. If I forget these two and just put crowns on the teeth, then this is not happy. The TMJ is not happy. Muscle is not happy. And finally, what happens? There is no stomatognathic equilibration that is happening inside the cranium as such. And when there is no equilibration, the restorations that you have given over the teeth would fail over a period of time, simply because there is no balance. If I have to create a balance, I have to come in an order. And what is the order? The first thing is your TMJ. The first thing is we need to look on to the signs and symptoms of the temporomandibular joint. We need to look on to the signs and symptoms of the muscles that are surrounding the stomatognathic system. We need to look on to the signs and symptoms of teeth that are there inside the socket. So come in this order. When you take the history from a patient also, always take the TMJ into consideration first. Ask the patient, what are signs, what are symptoms? Signs are what we see. Symptoms are what patient tells us. So ask the patient if the patient is having any TMJ pain. Ask the patient if patient is hearing any kind of sound when it comes to the joints. Ask the patient if the mouth is opening in a straight direction or is there any kind of deviation or deflection that is happening when the jaw is opening up and down. So all these are symptoms that we can get from the patient. If it's muscle, you can ask the patient if the patient is having any cramps, if the patient is having any muscular pain, if there is any movement of the jaw that is not normal, that is abnormal, that is happening. When it comes to the teeth, ask the patient if the patient is having any kind of mobility, if the patient is having any kind of sensitivity, if there is any tooth movement that is happening inside the jaw, inside the socket. All these are the symptoms that we are getting it from the patient. When it comes to the signs, what we see, what we feel, what we hear, all those things we need to note down. When it comes to TMJ, we have to see few things as signs and symptoms. What are those few things that we see when it comes to the TMJ? When it comes to the TMJ, the first thing what I would advise or suggest when it comes to any kind of equilibration case, any kind of full mouth rehab case is known as load test. What is load test? If you see this picture, you clearly understand that I'm holding the jaw anteriorly with one hand and I'm pushing the jaw posteriorly upwards with another hand. So what am I doing with this? See, if you see my hand, if I'm holding the jaw anteriorly with this grip, with the thumb on the occlusal surface of the molars, and probably with the other fingers on the undersurface of the mandible, I'm having a firm grip anteriorly. I'm trying to push the jaw posteriorly and backwards, backwards and downwards. When I do this movement, and when I lift the angle of the mandible posteriorly up, I am simulating a hinge that is happening inside the glenoid fossa. This movement, which is happening downwards and backwards and upwards at the angle of the mandible, will take the condyle into its anterosuperior position when it comes to the glenoid fossa. And that anterosuperior position is known as centric relation. Okay. The old concept of centric relation is posterior most position. What we used to see probably many years back. So we used to take a single hand and we used to push the jaw backwards so that the glenoid fossa, which is there, and the condyle, which is there, the condyle goes back with respect to the glenoid fossa. So when the condyle goes back and we restore in that posterior most position, what would happen at the max? The condyle would be going and hitting the tissue which is there at the posterior aspect of the glenoid fossa, which is full of blood vessels and nerves. That is known as retrodiscal tissue. It has a bilaminar zone which is full of blood vessels, which is full of nerves. So when I'm taking the condyle inside the glenoid fossa posteriorly, putting the condyle on the bilaminar zone or the retrodiscal tissue, which is full of blood vessels and nerves, I'm actually compressing that zone and creating pain for the patient because it's vascular, because it's full of nerves. Patient would be having pain every time patient opens up and closes in that particular relationship where we're giving crowns, where we are giving the full mouth rehab definitive restorations. I don't want that to happen. So what should I do? I should take the condyle into antero-superior position where the articular disc is very thin, where the articular disc is not having any blood vessels and nerves. It is avascular. It does not have any kind of nerves supply in the articular disc in that region. Then the patient, whenever he or she opens up and bites in that particular relationship, will not have any pain. The patient is happy. The joint is happy in its own space. And that position is known as your centric relation. So in simple words, centric relation is nothing but the antero-superior position of the condyle in the glenoid fossa with the thinnest avascular portion of the articular disc in between the condyle and the glenoid fossa. We need not by heart it. If we understand this way, it becomes very easy to understand the definition of centric relation. So if you see this picture, you will understand that I am trying to take the jaw into that anterosuperior position. I'm not trying to push the jaw posteriorly backwards onto the retrodiscal tissue. I'm trying to hinge it into the centric relation. If I do this first, before I start with the case, and if patient has pain, it means that when I'm applying pressure in the anterosuperior position, which is your centric relation, patient is complaining of pain. This is known as pressure pain diagnostic test, which is also known as load test. So if patient complains of pain when I apply load in this manner in the anterosuperior position, it simply means that the patient has some kind of intracapsular pathology. There is some kind of problem inside the joint. What is extracapsular pathology? The pathology is existing outside the joint, mostly a muscular pathology, something related to the teeth or the muscle. It's also known as occlusal-muscle disorder. But when I do this load test in the initial step itself and patient says, doc, I have I'm feeling sensitive in the joint region. When you do this, load test, perform this load test, then I'm almost sure. I'm not very sure. I'm not almost sure that there is some kind of problem that is existing inside the joint, and that's why patient is having any pain. So repeat this again, twice or thrice, and still patient says that stop it, I'm having pain. Then you might have to evaluate what is happening inside the joint. You might have to look into the joint, see what kind of intracapsular pathology that is existing by taking the help of MRIs, and then you need to solve it. You cannot proceed further. So the load test is a diagnostic test. To proceed further in cases of full mouth rehabilitations, in cases of any kind of stomatognathic equilibrations. So first perform load test. Only if it is negative, then you might have to proceed with other steps when it comes to the diagnostic mounting. Then comes to the jaw movements. Ask the patient to open up. In case the load test is positive, you might see one of these two things. Very common, two things that you might see in the practice is either deviation or deflection. These are intracapsular pathologies that we commonly see in our practices. Deviation is usually seen in disc displacement with reduction, and deflection like this is usually seen in disc displacement without reduction. So if you have load test positive, you might either see the disc displacement with reduction or without reduction. If you see some kind of movement like this, note it down that there is deviation, there is deflection. Once you take the MRI scan, everything falls in an order. You might get a provisional diagnosis or a confirmatory diagnosis saying that there is some kind of disc displacement with reduction or without reduction if the load test is positive and if you see something like this. Take a stethoscope and see for the sounds, hear for the sounds. Lot many times you might have clicks. A single click is not a worrisome factor. Most of us would have single clicks. It's not that thing which should puzzle your mind. Double click, yes, you might have to look into it where you might be having this with reduction, disc displacement with reduction, where the condyle is getting reduced, single click, and when it goes back, there is a double click. It's also known as reciprocal click. So look out for the sounds also, whether you have clicks, whether you have pops. The aggravated click is known as pop. When you hear a click which is loud enough, then it's called a pop. Sometimes you might have crepitus, where you have degenerative diseases of TMJ, where there is extreme thinning of the articular disc sometimes, and you might be having a sound where you just take some stones and put it in a vessel and then shake the vessel. How do you get the sound? That kind of sounds you get when it comes to the degenerative diseases, that is known as crepitus. So note down all these things. So start with TMJ. The important things when it comes to TMJ is load test, see for the mouth opening and closing movements, then probably auscultate the TMJ and then note it down. Then come to the muscle. In muscle, you have 4 muscles which you can examine, but I only examine 3 muscles when it comes to the practical scenario. The 4 muscles are your masseter, temporalis, lateral pterygoid, and medial pterygoid. I usually skip medial pterygoid because it's an internal muscle. It usually gives you false positive results. So I usually skip it, but the other muscles I examine and note it down. This is your masseter examination, this is your temporalis, and this is your functional manipulation of lateral pterygoid. Usually for lateral pterygoid, what is given in textbooks, most of the textbooks, is you go into the pterygomaxillary space and then probably feel for the lateral pterygoid. You cannot exactly go onto the condyle because lateral pterygoid is a horizontal muscle that is attached to the condyle. So I cannot go near the condyle and palpate for the lateral pterygoid, not practically possible. So arbitrarily we go into the pterygomaxillary space and see whether we can palpate the lateral pterygoid, and most of the cases it would be false positive because the moment you insert the finger, patient would become alert and say, I'm feeling sensitive here. So what we do is we do a procedure which is known as functional manipulation, where I take the mandible forward and the operator actually tries to get the mandible backwards. So what is the function of lateral pterygoid? The function of lateral pterygoid is it moves the condyle inside the glenoid fossa. It moves the condyle when inside the glenoid fossa, which is responsible for this protrusion as well as depression in certain cases. So when I protrude the mandible, it is the lateral pterygoid that is acting on the condyle, which is making the condyle move inside the glenoid fossa. So when the patient is protruding this way, the lateral pterygoid is activated. Now, when the operator tries to push the mandible backwards, there is a fight between the operator and the lateral pterygoid, which is already activated. In this fight, if patient finds some kind of pain here, it means that there is a lateral pterygoid, hyperactivity that is happening inside the system. That's why it's paining. That's why it's tender. And this is known as functional manipulation. This is more logical than just taking your finger and then keeping into the pterygomaxillary space and then finding out if the lateral pterygoid is tender, which is false positive most number of times. And once we find out all the muscles, which are tender, if the masseter is tender, then there could be some kind of parafunctioning that is happening inside the oral cavity. You see a lot of bulldog faces. The masseters are like, hypertrophied in some cases. If the temporalis is tender, you might have some interference inside the oral cavity. That's why it's tender. If the lateral pterygoid is tender, you might be having some kind of interferences inside the oral cavity. That's why it's tender. Having said that, when some kinds of patients visit our dental practices, when they say that I have back pain, I have neck pain, I have a lot of shoulder pain, I have a lot of pain around the face, not related to the oral cavity, the interference, tooth interference, which is there inside the oral cavity, could be one of the reasons for even having a back pain, for even having a shoulder pain. That small interference, if it's eliminated in the form of equilibration, patient recovers. That's why we are called oral diagnosticians. Probably if an ENT says that everything is okay with the ear, if an orthoped says that everything is okay with the back and the shoulder, and if an ENT again rules out any kinds of sinus pathology, then we as dentists need to look out into the oral cavity, find that first point of contact or interference, and then remove it or eliminate it. Once we eliminate it, then now the centric relation is equal to maximum intercuspation. All the muscles which are hyperspastic, which are hyper excited in the system, they relax because there is no interference that is acting now on the muscle. And once they relax, the pain comes down. So please remember this, keep this in mind, that if at all patient comes to you with post-auricular pains or headaches or eye pains or back pains, if other departments rule it out, if the general medicine, orthoped, ENTs rule it out, then you might have to think in this aspect that occlusion might be a causative factor, might be an etiology for these pains inside the human body. And we might have to step in, find that first point of contact. And the purpose of finding the first point of contact, the procedure that we do for finding the first point of contact is known as your diagnostic mounting. So we are done with TMJ, we're done with muscle, and now comes to the teeth. When it comes to the teeth, the first thing what we do is we capture a picture, intraoral picture this way. It means that we are capturing static occlusion. So what is static occlusion? Just opening and closure of the jaws inside the stomatognathic system. Then we ask the patient to come forward. So this is one of the pictures of static occlusion where you have anterior teeth contacts. Please remember that in complete dentures, we usually keep an overjet and overbite. We don't have these anterior tooth contacts. But when it comes to natural teeth, when it comes to full mouth rehab cases, fixed restorations, definitive restorations, you might have to have an anterior contact in between the maxillary and the mandibular incisors in a very, very light manner. You need not have to incorporate very heavy occlusion there, but a very light grazing contact should be there in between the anteriors. It's not like complete dentures where you have overjet and overbite and an open bite in the anteriors. We're trained with that, complete dentures. But when it comes to fixed restorations, please remember this should not be opened up. There has to be a contact, but the contact has to be very light. Okay, why you should have this contact, you will see in the next picture. If you see here, the jaw is traveling forwards. Now, when the jaw is traveling forwards from this position to the edge-to-edge position, you are seeing something in the posterior area. You're seeing posterior disclusion that is happening in the posterior area. So when I don't have this anterior contacts, I would not see a posterior disclusion immediately when the jaw is moving forwards, because I still have this gap that needs to be covered. If I have an anterior contact, then the palatal surfaces of the maxillary incisors would guide the jaw, lower jaw, with immediate posterior disclusion. That immediate and progressive posterior disclusion is very, very important for all the muscles to be at rest, for the TMJ not to be under any kind of pressure, any kind of tension. The posteriors are not rubbing against each other if you are having the immediate and progressive disclusion. So there is no wear that is happening on the posterior teeth. This kind of occlusion is known as mutually protected occlusion. What is mutually protected? Posteriors are helping my anteriors in static occlusion by taking a lot of force. Maximum force is taken by posteriors, minimal amount of force is taken by anteriors with minimal amount of contact. That is known as static occlusion in mutually protected occlusion scheme. When it comes to dynamic occlusion, when the jaw is coming forwards, the anteriors are guiding the jaw by having immediate and progressive posterior disclusion. So now my anteriors are protecting the posteriors from where? My anteriors are protecting the muscles from hyperactivity. My anteriors are protecting the joint, the TMJ, from getting disturbed. This is known as protrusive mutually protected occlusal scheme. And what happens in side movements? And if you see here, there is only one tooth that is guiding, it is harmful. You should have at least 2 teeth contact or 3 teeth contact or 4 teeth contact when it comes to the protrusive movement. One tooth, no. This tooth might go for a toss or this tooth might go for a toss later on. It might become mobile. So you should have an anterior group function when it comes to mutually protected occlusal scheme. In the lateral, when the jaw comes to one side, you should not have this picture. If you see here, all the posterior teeth are taking up the contacts, which is harmful. Only the canine should guide the jaw in lateral movements, because the canine is the longest tooth. It is surrounded by hard cortical bone. It can take up the stress in the lateral movements when it comes to the jaws. The more number of contacts posteriorly, the more number of oblique forces that are falling in the lateral movements when the jaw is moving side to side. I don't want that. I want only the canine to guide, so that the other posteriors are taken away from these oblique or tensile forces and the system is stabilized. This is known as canine guided occlusion. Suppose the canine is weak, it is periodontally weak, then yes, I can spread one premolar into the occlusion and take a partial group function, or till the mesiobuccal cusp of first molar, converting it into a full group function. So the indication of group function is only if the canine is weak. If the canine is absent probably, or if there is any kind of implant in the canine region, you might have to go for group function. Otherwise, just go for canine guided occlusion, which is the golden rule when it comes to mutually protected occlusion. This is again a picture which you should not have. Saying this, if I see these things inside the oral cavity of a patient, and if patient is not having any signs and symptoms, patient is happy, patient is not having any kind of problem, then it is known as adaptation. Let the snake sleep. Let the snake sleep. Don't take a stick and then beat the snake. It will hiss back. So in cases where you have adaptation, where you don't have any kinds of signs and symptoms, you tell the patient there is some kind of problem happening. Be alert. If you see any kind of symptoms, or you come for me once in 6 months, let me see for the signs. Signs always precede symptoms. Okay, signs always precede symptoms. So recall the patient once in 6 months, check out for these signs. If there is an occlusal wear, if there is any kind of abfractions that are happening, incisal wear, palatal wear, mobility. So check for all these things, and then probably if any of these things appear inside the oral cavity, then you alert the sleeping snake. You tell the patient, let's go for some kind of equilibration. Let's do some kind of equilibration inside the oral cavity. Otherwise, you just tell the patient that there is a problem existing, be alert, and then come for a checkup. So what is the summary now? First, do load test. If it is positive, it might be any kind of intracapsular pathology. Go for MRI scans, find out that intracapsular pathology, and treat the TMJ first. Without treating TMJ, don't come onto the teeth. Don't do full mouth rehabs. Don't do any kind of equilibrations. The TMJ will hit back. The patient will land up in more problems. So first, keep the TMJ happy in its centric relation. And then if the load test is negative, if there is no problem with the TMJ, then it could be an extracapsular pathology, which could be related to the teeth or to the muscle. Then the first step, what we do is known as deprogramming, muscle deprogramming. So we have different kinds of deprogrammers that are available in the market. You can deprogram with any kind of this stock or custom-made deprogrammers that are available in the market. I will not explain this in detail because we don't have that much time. But to summarize what is deprogramming, we are taking the posterior teeth away from each other by at least 2 millimeters from the posterior most supraerupted tooth. It means that I am avoiding contacts in the posterior area as well as in the anterior area, if you see here. So I'm introducing an anterior platform, making sure that the posterior teeth are going away from each other so that there is no interference that is existing inside the oral cavity. Only when I close, there would be interference. And once the interference is eliminated by deprogramming, there is no signal that is sent from the interference to the brain and in turn from the brain to the muscle, to the lateral pterygoid. So if there is no signal, if the signal is cut off, then the lateral pterygoid, which is activated because of the interference, calms down, relaxes. And once it relaxes, the condyle goes back to its state, which is happier, which is comfortable inside the glenoid fossa, and which is known as centric relation. So it is easier for me to guide the jaw into centric relation when the lateral pterygoid is relaxed. I can take it well inside the glenoid fossa. To make the lateral pterygoid relaxed, we do a procedure which is known as muscle deprogramming. So this is your Lucia jig, which can be relined inside the oral cavity. This is your appliance, which is known as nociceptive trigeminal neuralgia inhibition system. This is your Cois deprogram, which is one of my favorite deprogrammers, which I use. This is your leaf gauge. If you don't have any kind of problems with the system as such, clinically you can do deprogram with a leaf gauge. The only disadvantage is if you're not experienced using a leaf gauge, you might distalize the condyle back inside the glenoid fossa, but that's very rare. Leaf gauge can be safely used clinically as well to deprogram it. This is your NTITSS I just told you, and this is your unwind, which is there in the market. This is your custom-made patent resin deprogrammer. So you can use any of the deprogrammers according to the indications. It's a very long subject to be discussed, but yeah, do it and then deprogram the system. And once we are done with the deprogramming, probably over a period of time, usually I take 7 days to 10 days to deprogram. I don't prefer chase side usually, nor your 24-hour, 48 hours, though there are indications for it. Once the patient comes back to me after 1 week or 10 days, then I guide the jaw into centric relation. Usually this was a single-handed technique which we used to follow. This is also known as Anderson's technique. We used to keep the thumb and then we used to guide the jaw back and then close the jaw into centric relation. I'm not very sure with this technique because I'm not sure whether I'm taking my condyle in anterosuperior position. I might distalize the condyle into the posterior most position in such technique. So what I follow is Dawson's bimanual manipulation technique, where I keep the thumbs on the anterior portion of the chin, the other fingers on the base of the mandible from the midline on the undersurface till the angle of the mandible slightly posterior to it. So when I have this C-shaped grip, I can easily guide the jaw into centric relation by telling the patient to open up maxillary and mandibular teeth against each other. We are not closing the jaw and doing it. We are trying to tell the patient to open up and romancing the mandible and guiding the mandible very gently. We're not forcing it. We are not doing thud movements. We are gently guiding the jaw into its anterior-superior position or hinge position. And then performing a load test again. So load test is twofold. Load test is being done before we start up with the full mouth rehab case. It acts as a diagnostic step. And once the load test is negative there, after taking a centric interocclusal record, we are again doing a load test just to make sure that the centric relation is correct inside the joint. If the load test is positive here and patient says I'm having sensitivity when you perform load test after you take the record, centric interocclusal record, then it means that probably you have not taken the condyle into its anterosuperior position. You might need to repeat. So load test is twofold. And this is the direction how we perform the Dawson's bimanual manipulation. Here we perform backward and downward movement. Here at the angle we lift it up. Just like the lotus which we performed in the initial stage with one hand, here we are doing with two hands. So that the centric interocclusal record is taken. So you take the record without the deprogrammer if you're experienced. You can take a deprogrammer, you can start trimming the platform of the deprogrammer till you achieve that first point of contact, and then you can take a record, or you can take an alu wax interocclusal record and then take it with the deprogrammer. If you see here, I've cut down this portion here to accommodate the deprogrammer in this space. So you either use addition silicon medium body, you either use your interocclusal records in the form of alu wax or bite registration paste, anything which is convenient to you. Please don't use modeling wax because it is not dimensionally stable. There is no other criminal activity that we are doing by using a modeling wax. I don't mean to say that. I don't want to be harsh on that point, but just because it is not dimensionally stable, kindly refrain from using a modeling wax. Alu wax is better. Now taking this centric interocclusal record by deprogramming, that's the first muscle deprogramming, we mount the mandibular cast in relation to the maxillary cast. This step is known as diagnostic mounting. So we're doing all this circus till now just to get the mounting of the maxillary and mandibular cast in centric interocclusal record. That's it. We are not following the maximum intercuspation here. We are guiding the joint to centric occlusion and then mounting it. What's the use now? If you see here, if I open up if I remove the centric occlusal record, you have a lot of space now. This space is the space that the centric interocclusal record has occupied when we mounted. If I open up this incisal pin, now what happens? The maxillary member will drop down straight onto the mandibular cast. Once it drops down, remember this is dropping down straight in centric relation. It is not dropping down straight in maximum intercuspation. It's just dropping down in centric relation. So when the maxillary member touches the mandibular member in centric relation, you can easily find out that first point of contact now in between the maxillary and the mandibular cast here by just putting one articulating silk. You take a piece of articulating silk, place it between the maxillary and mandibular cast, and tap, tap, tap. You will get the first point of contact. And from that first point of contact, now you decide whether you have to go for selective grinding, whether you have to go for full mouth rehab, whether you have to go for orthodontic procedure, or whether you have to do some kind of surgery where there is prognathism of maxilla or mandible in a severe fashion. So this is how we plan the treatment as well from the diagnostic mounting. Not only to find the first point of contact, but what we have to do from that first point of contact is what we need to understand from diagnostic mounting. There is one more step which is known as protrusive records, which you can take with modeling wax because we are using these protrusive records on the mounted semi-adjustable articulator in front of you at the same time. So we're not actually storing these records for a period of time and using them. You can use your modeling wax. Take protrusion 6 millimeters anteriorly from the centric relation and take these protrusive records. You can set the horizontal condylar guidance on a semi-adjustable articulator using these records. So what happens in protrusion? The condyle is traveling inside the glenoid fossa. That is known as HCG, horizontal condylar guidance. So if I take a protrusive record, I'm recording the HCG of the patient with this protrusive record. Now I keep this protrusive records on a semi-adjustable articulator. I can simulate the horizontal condylar guidance on a semi-adjustable articulator in the same fashion or nearer to what I achieve in the glenoid fossa of the patient. It might be shallower than what it is in the patient, but it is always beneficial if it is shallower. Okay, so this is your centric interocclusal record. We open up like this, and now we drop the maxillary cast onto the mandibular cast. Now, if you see here, I have this first point of contact somewhere. That's why all the other teeth are opening up. And now, if I place articulating silk and check, I will see that first point of contact somewhere. Okay, so from this first point of contact, you're diagnosing, you are planning the treatment. You can also increase the vertical dimension if it is needed. Vertical dimension is an overhyped concept. I'll not discuss that in detail. It is not related to the present subject, but most of the cases you don't need to increase the vertical dimension because there is something known as dentoalveolar compensation that happens inside the stomatognathic system. Only if you need space for an anterior restoration, you might have to change the vertical dimension. Otherwise, most of the cases we stick on to the vertical dimension that is existing inside the oral cavity. And that in that vertical dimension, we do a diagnostic wax up also for full mouth cases. And then we proceed with the final restorations. So diagnostic mounting is multifold. It can help you in diagnosis, it can help you in treatment planning, vertical dimension, as well as the diagnostic wax up, which is the final blueprint of the definitive restoration. Treatment planning is multifold again. You can do selective grinding if the interference is very small. If you are doing some kind of anomaloplasty, which is nearer to the central fossa, you can do selective grinding. If the interference is falling slightly away from the central fossa, where we need to sacrifice more of enamel, you can go for prosthodontic full mouth rehabs. More away from the central fossa, where you need to sacrifice more amount of enamel, then you might have to go for repositioning, which is known as orthodontics. And finally, if these three give up, you might have to go for surgical procedure and make sure that the final occlusal scheme is mutually protected occlusal scheme with no interferences between the centric relation and maximum intercuspation. That's the final objective of stomatognathic equilibration or a full mouth rehab case. And diagnostic mounting helps in this finally. If you see just some slides of few cases, I'll just brush up fast. So this is the Facebook record, this is the centric record, mounting, HCG, and then probably from here to here, from here to here. That's how my diagnostic mounting helps me to achieve the final result when it comes to reorganized occlusion here. This is another case where we can also make stabilization splints with diagnostic mounting. This patient was a diurnal bruxer. If you see here, there is no posterior disclusion group function that is existing all over. So we needed to change that into a mutually protected occlusion with no interferences. Okay, we take the records, we do a diagnostic mounting. From there, we drop the cast. We find that first point of contact. If you see, there is a first point of contact here in the anterior somewhere. That's why there is a typical diurnal bruxism that is set in because of this wear. See how well the first point of contact has been noted or achieved with the diagnostic mounting. Can we find out easily inside the oral cavity? Not easy. Might be a tough job. And then we make a stabilization splint in mutually protected occlusion with dots at the back and lines in the front. Dots at the back is static, lines in the front. Without lines in the back is your dynamic occlusion in protrusive as well as laterotrusive movements. That's how we check it inside the oral cavity without interferences in mutually protected occlusion. So on summary, positive load test, don't deprogram, don't do diagnostic mounting, don't proceed with full mouth rehabs, don't do any kind of stomatognathic equilibration. First, find out what is there in the TMJ, then sort it out. If it's negative, deprogram, take a Facebook record, centric record, mount the maxillary and mandibular cast in centric record. This is known as diagnostic mounting. So thereby I end the session by saying that teaching is a great way to keep learning as well. As teacher, we are students as well. And this is my mail ID. If you have any doubts about any kind of full mouth rehab cases or equilibrations, you are free to contact me on this mail ID. Thank you so much for having me here. Thank you, team. You're doing a wonderful job. I hope I have not taken more time.
No, it was a very informative session, sir. Thank you. Teaching is a great way of learning, and thank you for sharing all those tips and tricks. diagnostic mounting, though it is important, I don't think everybody is taking them though that seriously. uh, so thank you so much. Shall we go ahead with the questions?
Yeah.
Okay. So how do you transfer the selective grinding done on cast in the patient's mouth intraorally?
So what we do is when we do selective grinding, first what we achieve in the centric relation as the first point of contact, we grind it away. If we have selected the case for selective grinding as such, because we have different kinds of equilibration. The first kind of equilibration is selective grinding. We note it down. There is a point, first point of contact on the buccal incline on this cusp, probably 1.6 or 1.7. We note it down on a paper. And then once we remove that first point of contact, the jaw goes into maximum intercuspation because we have removed that interference now in centric relation. Once the jaw goes into maximum intercuspation on a semi-adjustable articulator, then again we tap, tap, tap in maximum intercuspation to see if we are getting that dots at the back and lines in the front, what I have shown in the picture. If we are not getting it, again we are taking a burr and probably removing those points which we are having on the teeth in the posterior area till we achieve these dots at the back. What do I mean by dots at the back? The functional cusp to the fossa contacts. In simple words, when it comes to, because it's natural teeth, we might intend to keep few marginal ridge contacts also. So we keep writing, note it down on a paper. Like this tooth has this first point of contact. This tooth has the second point of contact. Till we achieve at least two functional cusp to fossa contacts in the posterior, we keep writing down, we keep doing this selective grinding on the cast on a semi-adjustable articulator. Now we have a blueprint ready. I can take this in front of patient, target that particular tooth and start doing my selective grinding. So the 2-hour procedure which we do inside the oral cavity now becomes probably a 20-minute procedure because we have already done our homework on a semi-adjustable articulator.
Right. Another question: do we need to raise the incisal pin before mounting?
Yes, why not? I mean, if in case, see, we need to do something known as zeroing of articulator, where we keep the incisal pin at the zero, especially. Okay, so once the zeroing is done, we don't disturb it. We don't disturb the mechanism as such. We just mount the maxillary with face bow and we mount the mandibular with centric interocclusal record. After that, we touch the incisal pin. So before we do all these mounting procedures, we don't touch the incisal pin nor raise it.
So we have to keep it in the zero position.
Zeroing has to be done and then we mount it.
Okay. Another question: which articulator would you recommend? Low cost and sturdy articulator between Adler, Corrident, and BioArt. So I think a prosthodontist only is asking this question.
Yeah, I mean, I've used all these three. I would not say that you have to confine for a particular articulator because this is more of science than, probably marketing a particular product in a session. But I have found CSA to be more convenient. I'm not advocating nor I'm promoting any product here, but CSA I found more convenient because it is easier to use a Facebook when it comes to a CSA. It is easier to mount a Facebook record when it comes to a CSA articulator. Either 400 or 600 is fine. You can choose any one of these two things. CXA, I found it is more convenient when I compare it relatively, probably.
Another question: you mentioned deprogramming device which needs to be worn for some time. So are there any instructions that needs to be given to patient during that time?
Yes, patient has to wear the deprogrammer all the time, except when the patient is eating on something or chewing on something. Rest of the time, patient has to be on a deprogrammer, and patient has to come to the office, dental office, wearing the deprogrammer. Patient should not remove the deprogrammer, let the teeth contact, and then see you, because whatever you have done over a period of time, over a period of 1 week, is just gone if the patient bites on teeth again. So these are the two instructions which we need to tell the patient. Has to be on deprogrammer all the time except when the patient is eating. Patient has to come back to us with a deprogrammer on inside the oral cavity.
Okay. Okay. I think last question for the day. If we don't have a vertical stop, then should we directly go for centric relation?
Yes. If you have teeth, you have maximum intercuspation. If you don't have teeth, we have to depend on joint, and that is your centric relation. As simple as that.
Okay. Okay, Dr. Surabhi. So those were the questions. Thank you so much for sharing all the tips and
Pleasure.
tricks and the details. And I must say, I have got so many comments. Super session, outstanding presentation. It was a walking, talking Dawson with extraordinary oratory skills. So
Of
that was
course.
Dr.
Thank you so much.
Yeah. Thank you so much, Dr. Surabhi. Thank you. It was a pleasure having you. Thank you.
Pleasure. Pleasure. Same here. All the best to the whole team.
Thank,
Doing well.
thank you.
Bye bye.
Bye. And that was Dr. Surabhi Mahidhar, and I am super glad that we had this session. Though I will need some time, I will have to revisit, but I am super sure that all the prosto PGs and all the prosthodontists would have gained a lot from his experience. So thank you, team DIDC also for bringing these speakers on board, and thank you to you all who are listening to us and you come every weekday and weekend, Thursday and weekend. So thank you so much. And yes, keep coming. There are 4 sessions left. Almost I will say 8 to 10 speakers left. So yes, more than that actually. So yes, you need to be here, and I am going to see you next on Saturday. Let me tell you some quick pointers that you need to take care of. One is you still have few days left. If you saw Dr. Rumpavic's session, if you I hope you were there. So there's a questionnaire, the form is available on YouTube, on DRDCA page. Kindly fill it and send the answers, and you might be the lucky one to get prizes from Pulp Dent, and Dental Products is sponsoring this. So thank you, Dr. Rumpa, for being so sweet to give us this gift. I hope I wish I could just get them. But yes, you can try your luck, guys. Another thing that is happening is, again, you have to download the app and register yourself. And then this, what you need to do is, you have to be active in scientific sessions. You have to comment, you have to share, tag your friends, take screenshots while doing it. Also, join FBDRDCA page and send those screenshots and details to drdca2020@gmail.com, and you might be the lucky one to win this Novalace laser therapy machine. So, and in case you have any doubts about using laser, there are some lectures that have already happened, already taken place, so you can revisit them on YouTube, FB, and app also. On app, the benefit is directly you get the contact details, you get email on at one place, so you need not go here and there. So a lot of things. So yes, and it hardly takes anything. Registration is free of cost. It's still going on. If you have missed, please download the app and register yourself. So on that note, let me finish today's session and let me tell you what is in store for Saturday. So Saturday we have speakers joining us from Japan, India, and UK. Dr. Jiro, Dr. PC Jacob, and Dr. Menaka Pothalingam. Dr. Jiro and Dr. Jacob will be there in morning session, which starts at 11, and Dr. Menka will be there at 4 p.m. session, for 4 p.m. session. They will be talking about the suction mechanism of mandibular complete denture, which I'm really interested in. And then post and core. Yes, post and core will be taken up by Dr. Jacob in the morning session of Saturday. And then there is a very interesting topic which Dr. Menka is still talking about, and that is effective leadership through turbulent times. I think need of hour. So yes, I'm looking forward to these sessions. So should you look forward to these sessions? Download the app if you have not. Fill the form. Apply for lucky draw competitions, and yes, stay tuned till we International Men's Day. For all the female colleagues, wishes, just extend these wishes to your dads, to your fathers, to your husbands. Thank you so much, guys, and I'll be seeing you on Saturday. Bye bye, take care.